Good morning, good afternoon, everyone. Just letting we can see how the numbers ticking up as everybody joins today's seminar. So welcome. And I'll just welcome you on behalf of the Berman Institute and then hand over to Mary Catherine, my colleague, to introduce our speaker today. So if you haven't joined a Berman Institute seminar before, this is about 1 hour long seminar. Invited speaker you'll hear a little bit more about in a moment. We'll have about 45 minutes for presentation, followed by 15 minutes or so for question, answer, and discussion. If you do have a question, feel free to drop it into the Q&A module at the bottom of the screen at any time, and we'll take them in order of appearance. If you'd prefer to raise your hand and speak your question out loud, you're welcome to do that as well. So just use the hand raise function on the screen. And the same thing, we'll try to take those in turn. So I won't hold you back anymore from today's wonderful speaker. We're delighted to have join us, and we'll hand over to my colleague, Mary Catherine, for an introduction. So over to you, Mary Catherine.
All right, thank you. Welcome, everybody. I am quite excited for today's seminar. I would like to introduce Dr. Vikki Entwistle. Dr. Entwistle is a professor of health services research and philosophy with academic homes in both the Health Services Research Unit on the University of Aberdeen's Forest Hill campus and philosophy on the Old Aberdeen campus. Her research and teaching are highly interdisciplinary. Broadly speaking, she uses philosophy and social research to understand and address concerns about quality, ethics, and social justice in healthcare, public health work, and more recently, funeral provision. She is particularly interested in what are sometimes called person-centered approaches to service provision. She often uses feminist theorizing and capabilities approach to human well-being in her work. Without further delay, I would like to welcome Dr. Vikki Entwistle to begin the seminar. Welcome, Vikki. We're very excited to have you.
Thank you, Mary Catherine, and I'm very excited to be here. I'm going to talk today about connecting bioethics with healthcare improvement. And my talk is based on a collaborative research project that I'm conducting with Professor Alan Cribb and Dr. Polly Mitchell at King's College, London. And the work is funded by the Wellcome Trust. And the reason I've chosen to talk broadly about this project is that we set out to investigate what applied philosophy and ethics can bring to quality improvement. So obviously I'm hoping to entice some of you who are working in bioethics but haven't yet worked on healthcare improvement to think about that as an area of interest. So the project, as our ambition initially was to work particularly closely with healthcare partners to help address debates about quality and to understand how some of the ethical challenges of improvement work could be better managed. Because of the COVID pandemic, some of our plans for embedded working with healthcare improvement teams within the National Health Service had to be modified, but we have been able to conduct a range of activities, including some agenda setting interviews with, or key informant interviews with healthcare improvement specialists who were seen as leaders in their national or even international fields. We've undertaken some critical reflection work with improvement practitioners, including a clinician who introduced poverty screening, a poverty screening tool as a quality improvement exercise. And we looked with her at some of the affordances and disadvantages of framing that initiative as an exercise of healthcare improvement. And we've worked with some operational researchers who are grappling with the challenges of modelling efficiency, and I'll say a little bit about that later. The work has included particularly analyses of quality concepts and their implications, and to a lesser extent, but still we think this is very important, analyses of improvement tools and initiatives, including we've thought a little bit about routine measurement for continuous improvement. And we did some work examining a national professional curriculum introduced in the NHS, the National Health Service in England, for personalised care. So that's a bit of background to the project. I suppose the one overarching message is perhaps a bit too strong, but the point I want to communicate for this seminar is that I think bioethics has what seems to be some undertapped potential to look critically at and to contribute to healthcare improvement, and perhaps to benefit from engagement with healthcare improvement specialists as well. The ideas of quality and the policies and practices of healthcare improvement have considerable social impact. You're probably aware of, to some extent, the scale of investment in improvement activity, both within health services and beyond. Institutions like the Institute for Healthcare Improvement having quite significant influence and impact. And they also raise important ethical questions that don't seem to have been subject to a lot of ethical attention. Perhaps in part because healthcare improvement doesn't fall clearly and neatly within the scope of either clinical ethics or research ethics or even public health ethics, and perhaps because the technology of healthcare improvement is somewhat diffuse. But I think the way that healthcare improvement intersects with clinical practice, with research, with public health and technology, makes it a particularly interesting area for bioethics work. I'm going to focus on illustrating some of the ethical questions or challenges that are raised in healthcare improvement, and I'm going to go range fairly broadly, so perhaps running the risk of being a little bit superficial with my illustrations. But I'm very happy to answer questions, or try and answer questions at least, and go into more detail in the discussion. And I've provided some references to some published work and forthcoming papers at the end, which obviously I can help you follow up if you would like to. One last preamble thing I think I should stress in saying that I think healthcare improvement merits ethical attention, I'm not saying that the field of healthcare improvement as a whole is unethical or plagued by lots of bad characters. Indeed, on the contrary, obviously the motivation to improve healthcare is good. Improvement efforts have often brought about good, and colleagues often take quite significant care to work in good ways, although it's perhaps notable that the efforts to work in good ways often focus on attempts to be methodologically robust and consistent with methodological standards, perhaps rather than ranging more broadly. But for all that healthcare improvement is a good thing at face value, we have to recognise that there is disagreement about what is good or better in healthcare, indeed about what constitutes better health and well-being. And that the improvement approaches and outcomes aren't all unequivocally good. There can be a spectrum of impacts. Improvement has costs, including staff time, and those costs can perhaps sometimes outweigh the benefits. And of course, the benefits and burdens of improvement, like many things, aren't equally shared. So there are ethical issues to be considered. I think I'd also note that a lot of the normativity in healthcare improvement is often implicit. The value assumptions within healthcare improvement are often taken for granted, and helping to bring those out is perhaps one of the ways in which I'll suggest bioethics can perform a useful role. For the rest of the presentation, I think I'm going to spend most of the time illustrating, or trying to illustrate, something of the normative complexity of improvement by briefly considering the concept of quality, person-centeredness and efficiency, and in between there by looking at some of the implications of measurement, which is an activity that's central to most, if not all, healthcare improvement approaches. I'll then briefly consider why conversations are important in the context of healthcare improvement, and considerations of why and how that makes things better, before I try and sum up briefly why I think bioethics has much to offer, or that I think bioethics has much to offer. So let's start by thinking about quality. What is quality healthcare, and how does that relate to good healthcare? In everyday talk, perhaps quality healthcare and good healthcare are more or less the same thing. And that might be the response if we were to ask patients with limited experience of health services. But quality in healthcare improvement is a foundational concept. And in health policy, health service administration, and healthcare improvement circles, quality has acquired a more focused and a somewhat technical meaning. So if we ask people who work in these spheres what quality healthcare looks like, we might get an answer that takes the form of a list, something like this. Quality healthcare is, for example, safe, effective, patient-centred, timely, efficient, and equitable. And huge credit to the Institute of Medicine for generating a list with such resonance and widespread durability. Of course, quality can also be defined in a more abstract way. For example, quality in healthcare is the degree to which a healthcare system or service possesses desired characteristics or achieves desired objectives. And this kind of definition raises questions about which characteristics or objectives are desired, questions to which the lists of dimensions of quality are clearly answers. This kind of definition can also help prompt us to ask a few further questions, such as desired by whom, objectives for which kind of services. And these questions usefully help us remember or realise that the lists of dimensions of quality are subsets of valued characteristics of health services, subsets of what can be important for good healthcare. So quality healthcare is a schematic representation of good healthcare. This is pretty obvious once you think about it, but it's also ethically important given the huge practical influence that the idea of quality has. But the idea that quality is, or the idea of quality as a schematic representation of what's good is easy to forget in practice because quality's become such a thing. And perhaps that too has led to some neglect of the ethical significance of improvement activities. I'll come back to this idea shortly, but for now I want to look a little bit further at the plurality and other sources of normative complexity relating to quality. And by normative complexity, I mean roughly the complexity of assessing what's good and what we ought to do about it. And I see normative complexity as complementary to and intertwined with the more familiar, perhaps more familiar idea of explanatory complexity, of the challenges of saying what effect something has in complex systems, of attributing causality, for example. So, plurality of quality. Whatever practical size list of dimensions of quality is used, other dimensions of quality can be identified. I've suggested just a few alternatives to the Institute of Medicine set here. And some of them will be seen as more important, at least by some people and some health systems or services. Different lists suit different contexts and purposes. The lists are all developed by some people somewhere and usually with some kind of purpose in mind. There's not a fixed natural truth about quality against which competing lists can be compared. So if we want to know which list is better or how good a list is, we perhaps need to ask how well the list was developed, how carefully, how thoughtfully, how inclusively perhaps it was constructed. Or if a list is being considered for use elsewhere, how fit is it for context and purpose? How well has that been evaluated? So I'm suggesting we need to consider these lists of dimensions of quality as pragmatic conceptual tools and then judge whether they serve good purposes when they're put to use. The dimensions on the list, safety, effectiveness, etc., also have contested interpretations. So the questions don't stop once we have a fixed list of dimensions or a settled list of dimensions. Indeed, perhaps interwoven into consideration of which dimensions are important are questions about what actually we mean by each of the value labels that we're proposing. The dimensions of quality can be and are variously interpreted. People can reasonably disagree about what exactly we mean by safe, effective, patient-centered, etc. What safety, effectiveness, and patient-centeredness should look like here. I'll say a little bit more about a couple of the dimensions in a moment, but for now I think I want to stick with the overarching notion of quality and think a little bit more about the dimensions and how they relate to each other. So on most lists, I think each dimension, safe, effective, etc., adds something particular. The dimensions aren't reducible into each other, but then neither are they conceptually or practically independent, and they're not simply additive. So for example, if we understand patient-centeredness to require a sufficient degree of relational equality between staff and patients, it's conceptually and probably practically connected to equity. And if we're implementing safety procedures, that takes time that might detract from some interpretation of timeliness. So you can't win the quality game in a health system simply by completing a discrete project on each of 6 dimensions, as if you're answering quiz questions about 6 topics to win a quiz. And the various dimensions of quality also have contested priority. People might variously and reasonably prioritize some dimensions over others. They might disagree, for example, about whether the blue or red service as represented on the diagram is delivering better quality care. They might also, I think, reasonably question the adequacy of the spider diagram as a representation, but that's not my focus here. And in part, all these differences arise because people consider quality and its dimensions from their different positions and perspectives, and perhaps bear in mind the different and contested roles and responsibilities that they take in relation to healthcare. But we can also note that the dimensions of quality can be focused on or applied to different levels, or they've got different foci. For example, patient-centeredness requires consideration at the level of an individual patient, while equity requires some kind of looking across a population. Effectiveness is often assessed as of particular drugs or surgical techniques, while efficiency is often considered at the level of a health system or service. And all of these are interconnected, so it gets quite complex, both conceptually and if we're thinking normatively. Questions about which dimensions are selected for attention, how they're interpreted and prioritized, reflect and have implications for whose perspectives on good healthcare are attended to, and whose needs and interests are given more or less weight. And those kind of selective judgments can be readily be considered as matters of ethics, perhaps justice. And even when we're thinking about quality as a goal of healthcare improvement, I think it's important to recognise the centrality of measurement to healthcare improvement approaches, and to note the implications of that for how we conceptualise quality and its dimensions, and thus for the shaping of improvement agendas. The characterisation of quality gets fixed and settled to a large extent because of commitments to measure quality that are and those commitments are integral to healthcare improvement, and they're also further required by various managerial and policy commitments. So if you've got some measures, you use them, and that shapes how you understand what it is you're measuring, or what you're measuring is taken to reflect. Let's think a little bit more about measurement. So measurement, as I've said, underpins healthcare improvement, quality improvement tools and strategies. And measurement is really useful and important. It gives us knowledge about healthcare, and that knowledge is used in improvement and other contexts to help justify claims about how good or bad healthcare is, and to support comparisons across time and setting. But it's important that we recognise that measures are likely to miss important aspects of good or bad healthcare. So there can be significant epistemic gaps, and that can also lead to practical neglect of what doesn't get measured. Whoops, sorry, just losing track of my notes here. And measurement doesn't always or automatically result in improvement, despite the beliefs that can arise from fallacious interpretations of quotations that tend to link measurement to improvement, such as "you can't improve what you don't measure." And measurement has costs. It takes resources, including staff time, and it can also have side effects, including the way it shifts ideas about what's important and changes accountability relationships as people modify what comes to be accepted as evidence. So we need to ask questions about how we consider which, for example, of two healthcare services is better. And I think we need both some measurement of performance on designated dimensions of quality and some space for more open-ended evaluative judgments of what is good. And there are important practical and ethical questions to be asked about how these two are balanced within healthcare systems and services, as well as how we can surface and elucidate important critiques when visions of quality become problematically narrow because of the reductive nature of measurement, or when undue reliance is placed on measures and their limitations become obscured. I'm going to offer a general suggestion about that towards the end of the talk, but now let me just summarize where I think we've got to so far. And if anyone wants to jump in and ask a question that's crucial before we go any further forward, please feel free. So where have we got to? Quality is a schematic representation of good healthcare. And when people talk about and work to improve healthcare quality, they're usually considering only a partial subset of what can matter for good healthcare. The construction and the application of quality concepts is value-laden and conceptually and normatively complex. And although this is often implicit, so these values aren't debated as people decide to focus on this or that aspect of quality and use this or that measure, it can be highly practically influential. So healthcare improvement activities focus on quality and use of particular measures shape both what is attended to, and that includes whose concerns and whose priorities, and how. And when the concept of quality is taken together with the measurement imperative that it's aligned with in the healthcare improvement framework, the quality schematic tends to reflect and promote quite a calculative approach without necessarily recognizing the tensions and difficulties that this involves, because it assumes and encourages every value can be and should be every value can be and should be operationalized and measured, even when that isn't necessarily the most helpful way of thinking about the value. So this quality schematic warrants critical ethical attention. And I think this attention includes, or that what's required includes attention to its various dimensions. And as we look at the value concept or dimensions of quality that are identified, the kind of sources of normative complexity and the concerns about measurement that we've seen when we were looking at the overarching idea of quality recur, somewhat fractal-like. Hence that's my excuse for using a nice image anyway, or an image that I like. So let's look first at person-centeredness. And I should perhaps say I prefer the term person-centeredness to patient-centeredness for various reasons in general, but it's not a hands-down win. And if you prefer patient-centeredness, that's okay. I think a variant of the argument I'm going to make can work, mini argument, it's not really a full argument. And if you so run with that if you want to, and we can chat about it later if you need to. So person-centeredness, widely accepted to be a good thing for health systems to aspire to. At least I think few people would publicly advocate that healthcare should be less person-centered unless they were interpreting person-centeredness in a very narrow way. But it's a slippery concept to pin down. And over the years, various behaviours and practices have been proposed as important to or central to person-centeredness, and a number of multidimensional definitions and various measures have been developed. In improvement contexts and also in a lot of health services research, the imperative to measure has often prompted calls for standardisation. But I and the But Why Is That Better team, project team, want to resist those calls to some extent and argue that there are reasons to think that some variety of definitions can be important, including for relevance and fit to different contexts, and also that vagueness can have value. I won't try to give the full argument, but hopefully we'll say enough to give you the gist. So a core or root idea of person-centeredness is that it involves treating the patient appropriately as a person. And that already tells us quite a lot because the concept of a person is morally laden. We have a range of ideas about how it is and is not ethically appropriate to treat persons in contrast with other kinds of entities. But if we were to stick with just that phrase, it's not immediately obvious how the idea of treating patients as persons should be enacted, how it should be operationalised or measured for improvement purposes in a healthcare setting. So as with the notion of quality, some specification of more practical dimensions can be useful. But these are, again, pragmatic constructions. There is no natural truth about person-centeredness against which the different accounts can be, or different characteristics or descriptions accounts can be judged. I'm going to ask you to look briefly at just two multidimensional accounts of person-centered care with a view to just glimpsing some similarities and some differences between them. So the first, developed by Nicola Mead and Pete Bauer, this one stresses things like seeing the patient as a person, also talks about acknowledging the doctor as a person, and a few other things as well. This one developed by Alan Lepledge and his colleagues for thinking particularly about person-centeredness in rehabilitation contexts. Talks about addressing the person's specific and holistic properties and their difficulties in everyday life, and respecting the person behind the impairment or the disease. So both connect to the idea of treating people as persons, but they do so in different ways. Each one adds some specificity and suggests some practical looking orientations or recommendations. But when we look across them, and we could develop a bigger set of these kind of characterizations or accounts of person-centeredness to look across, we're reminded that there's some ambiguity in the scope and the dimensions of the concept of person-centeredness. They don't all include all the same features, although there's quite a lot of overlap and commonality between them. And these ambiguities of scope and dimension are accompanied by another ambiguity that's really significant for efforts to measure person-centeredness. Should we view person-centeredness as a set of practices performed by health services and staff with particular kinds of intentions, or should we view it as a set of phenomena actually achieved and experienced by patients, or achieved in the experiences of patients? Whichever view you emphasize, the questions are going to arise about how adequate and how fair are the assessments that you make from it. So we can see both advantages and limitations to the additional definition that's offered by spelling out conceptual frameworks and developing measures. definitional frameworks help give some kind of public substance to a concept, to share what we mean, what exactly we're talking about, and they help practical operationalization. A highly specified set of measures can facilitate comparison. How person-centered is this service versus that one, or how have we improved in the extent to which we're person-centered in this service over time. But more precision isn't necessarily better. Different definitions and different measures suit different contexts. And we would argue that to secure the full value of a concept like person-centered care, you need to retain some scope to use the, albeit vague, grounding idea. We need space to ask and discuss of something we see or something that's offered as indicative of person-centered care. Is this really treating the patient as a person? So with person-centeredness, as with quality, I think there's a need to preserve some kind of breadth and openness that is threatened by a strong focus on measurement for quality assessment and for healthcare improvement purposes. And just in case you're thinking that the complex and contested normativity of dimensions of quality is restricted to the apparently softer ones like person-centeredness, let's look briefly at the concept of efficiency, the assessment of which is often taken to be a somewhat more technical matter. So efficiency is there in those lists of dimensions of quality because it's important that resources are used well. And efficiency involves measuring inputs or resources and outputs or ends with a view to either maximizing the outputs that can be achieved with given inputs, or minimizing the input needed to achieve given outputs, or somehow otherwise optimizing the relationship between inputs and outputs. But however neutral the concept of efficiency may seem in the abstract, when you come to populate the concept in practice, the selection of inputs or resources and outputs or ends is value laden. And I just want to illustrate this with one example, which is thinking about how we might assess and improve the efficiency of a nurse home visiting service. One way of doing it relatively straightforwardly would be to say, well, we've got so many nurse working hours, we count those as our input, and we achieve a certain number of, or we need to achieve a certain number of home visits, and we count that as our output. Sorry, my computer wants to restart. We won't let it. And one way of, if we take that as input and output, we might think relatively straightforwardly, well, we need to arrange the nurses' visits, plan the routes for their travel to minimize the nurses' travel time. And then assuming, and that might be a bit optimistic in some circumstances, sadly, that nurses' travel time is counted as part of their work hours, we maximize the number of visits per nurse hour by making the routes more efficient. But there are many more kinds of inputs and outputs that we might consider in the context of a nurse home visiting service. We might think of the degree of commitment of particular nurses as part of the input, the energy they expend, the emotional labour they use. But more likely, we're likely to think of a broader range of outputs or ends. So what, for example, is done or achieved in these nurse home visits? Hopefully something useful for the patient. How well timed are they from the perspective of clinical judgments of need or patient preference? Is there relational continuity? Do the nurses and patients get an opportunity to get to know each other? And is that useful if there's a scheme that allows generally the scheduling of same nurse to same patient? Assuming we've got a group of nurses with varying levels of experience and skill, how often, for example, do the nurses, the more highly experienced nurses, use their top skills? If they don't, does that impact on their job satisfaction? Does that impact on staff retention? To what extent is the emotional well-being of patients taken into account by the way efficiencies are considered, by the things that are taken into account? And as soon as we start opening up this broader set of inputs and ends for consideration, we see that there might be several ways to improve efficiency in some respects, but there's not going to be one way of making everything as good as it possibly could be all at once. So there are trade-offs involved. And some of the broader considerations of efficiency are less measurable and also more contestable. And they're also likely to be variously important to and impact differentially on particular players and particular areas or levels of service organisation. And some considerations are perhaps less appropriately integrated into mathematical models if these are being developed to try and promote efficiency. For example, a service manager might have good reason when allocating tasks or nurses to particular patients to share the work of caring for a particularly challenging patient around a team of staff, even though that limits relational continuity. They might also want to avoid scheduling two staff members who really don't get on well together for visits that require two team members. But they might consider it inappropriate to institutionalize that information by inputting it into some mathematical efficiency modeling program. So work on efficiency, I think, is ethically contestable. In practice, as soon as you start moving beyond the empty concept of efficiency and populating it, it has to be tied to other values. Operationalizing efficiency involves normative choices. Models of efficiency reflect those normative choices and influence the shape of service provision. And claims of efficiency gain are going to reflect those choices and so are unlikely to be unequivocal improvements. Excuse me. So for just pulling together, having looked briefly at person-centeredness and efficiency, I hope I've convinced you, at least enough, that for dimensions of quality as well as for quality overall, the goals of healthcare improvement and the ways in which they're specified and measured involve value judgments and have ethical significance. They need ethical attention. And although I've neglected them here, I think so do the various healthcare improvement strategies that can be adopted, such as audit and feedback, performance-based pay, improvement collaboratives, experience-based co-design, and so on. Before I conclude and try and stress that bioethics has a lot to contribute to healthcare improvement, I want to say something briefly about conversations. One notion that has struck us in the course of this project is the importance of conversations for countering some of the reductive pressures of measurement and for contributing to balance in the ways in which we consider which forms of healthcare are better. Conversations are also important for acknowledging and keeping sight of and managing normative complexity, and they have many important features in this context. I've listed some of them on the slide and perhaps I won't read all of them. I'll let you read them while I just take another sip of water. And conversations in healthcare improvement can be enabled or hindered and enacted in various ways and to various extents, including in routine practice, but they also feature formally. They seem to be key components of activities that are often associated with healthcare improvement and attempts to move it forward, things like multidisciplinary safety huddles, Schwartz rounds to improve staff well-being and support reflection on what needs to be improved and why, and experience-based co-design approaches which aim to bring together the voices of patients, family members, and service users to offer different perspectives on what matters and why and what could be improved. Sometimes those formal strategies are introduced as a compensation for the insufficiency of informal conversational opportunities. And in some of these formal contexts, people sometimes say or observe that skillful and knowledgeable facilitation can really improve the experience of participation and the calibre of discussion. Skillful facilitators can support deeper reflection and ask the kind of questions that enable constructive conversations about different people's value positions. And such facilitation might be a role that bioethics specialists can serve. We can see parallels, or I think there are important parallels with clinical ethics consultation skills and with group-based ethical reflection sessions. More generally, I hope I've illustrated and given sufficient hint of the potential for bioethics to help render the normativity of healthcare improvement and the concept of quality and associated dimensions more visible, render the complexity of that normativity more navigable. Bioethics can help, bioethics scholars and approaches can help elucidate both that and how discussion and measurement of quality and claims of improvement are partial. They can help to keep open and alive critical debate and the development of ideas about what's good. People with skills of ethical analysis are perhaps really well placed to keep the important but less measured and less readily measurable or less readily modelable considerations appropriately on the table. And bioethics can perhaps facilitate as well as contribute to conversations between diverse voices about what's good, what matters and why. Is there anything to be gained in return? Well, I think healthcare improvement perhaps offers bioethics an important domain for investigation and analysis, and improvement specialists potentially offer know-how for supporting the practical uptake of ideas about what should happen. I think that's all I had for now. Thank you very much for listening. I can't see you all listening, but I'm assuming that you have. And I'd be really happy to hear any comments or take any questions. And if you don't want to talk now, there's some contact details. And if anyone wants slides and references, there are some that I can share easily afterwards. But for now, thank you very much indeed.
Thank you so much, Vikki. That was wonderful. We have one question in the chat, and I'm going to see if we can call on Travis. And can we unmute Travis to talk?
I believe I'm unmuted. Can you hear me?
Perfect. Yes.
Excellent. Thanks so much, Dr. Entwistle. Very interesting. So I think I'm convinced, like, immediately by the basement sort of claim that you're making, because I'm a philosopher by training, and when I found my way into working on the ethics of opioid prescribing in the US, one of the first things that happened that shocked me was that a bunch of healthcare quality improvement networks reached out and said, hey, can you come talk to us about, improvements in opioid prescribing? And I had no idea, what was supposed to be my expertise in this, very separate field as far as I could tell. And so one of the things that happened is I started saying things like, they would give me a goal sheet about, we want to reduce the number of opioid pills prescribed. And I'd say things like, well, that's not the right goal at all, because we don't know anything about how many should be prescribed. And so a reduction in number isn't helpful. Like, we need values here. So I basically just shouted a bunch of things that sound like they rhyme with what you said. So here's a question that I have that's very open-ended, but I would love to hear if you have any thoughts. As I've been working in the space for now 5 or 6 years, I get asked to sit on a lot of guideline sort of comments, groups, workshops. And I hear from patient advocates that guidelines are basically inherently in tension with patient-centeredness or person-centeredness, that there's something about a guideline that turns patients into data points rather than individuals. And And I actually see that feedback being taken up some, because when guidelines are then revised in response, so again, my area here is opioid prescribing, when they say, oh gosh, we do need to include the patient more, they get more and more nuanced to the point where it's not actually clear that the guidelines have a clear mission anymore. It just sounds like do good medicine, like promote good and minimize harm justly and equitably while like scaffolding autonomy. So I guess I wanted to hear whether you thought that this is in fact a sort of high level overarching tension between trying to put out generalizable guidelines that improve quality in some domain and then maintaining patient-centeredness, or whether we've lost our way somewhere.
Yeah, thanks, Travis. I think that's a really important question. And so I think I do think there are tensions between efforts to standardize healthcare and to individualize it. And the questions of when is it appropriate, for example, to deviate from a recommendation, from a general recommendation, because this patient has different characteristics or what have you, I think is really difficult to answer. And I think, so I do think there's a real tension there. I think it's also a difficult tension to get to grips with. And are we talking about, because guidelines, as you've indicated, are not all, they don't all work in the same way. They're not all constructed. Some have more flexibility built into them than others. And that flexibility might be more and less responsive to the things that most good clinicians and most patients would recognize as important, encouraging you to be responsive to important differences, to salient differences. But also I think the way guidelines fit into a broader scheme of professional education or knowledge resources or performance frameworks are also significant, because I think sometimes if guidelines are seen as just guidelines and they summarize relevant evidence about what works well for these kind of people generally, these kind of people is not quite the right word, but this patient group, and what kind of features of patient characteristic or patient preference would warrant a different approach. Now, how much flexibility is built into the guidelines is one thing, and how much flexibility are professionals seen to have when applying guidelines, or are they going to be beaten over the head with a stick if they don't follow a particular recommendation? I think all those are important questions. The answers vary in the messy real world, and yeah, I think there are some real tensions, and probably again with that, looking at some of the specifics in detail, in particular contexts, what's going on, what do these guidelines say, how are they being interpreted, what flexibility do and don't they allow, and what is it that they're constraining, are really worth some detailed investigation. And I'd love to see you do it.
Well, thanks for that. That was super fascinating and very thorough. I'll just say I feel validated that the answer is it's really hard. So thanks.
Thanks. I think Joe has a question.
Yeah, thank you very much, Dr. Entwistle. Really interesting work, and I think it intersects with some of the work that other colleagues here at the Berman Institute are doing in relation to thinking about how to conduct and oversee, from a sort of regulatory perspective, the quality improvement activities within an institution where they intersect largely with clinical practice and sometimes with research. And anyway, but my question is actually a little bit off of that, from that, and picking up, I think, on something you had mentioned about quality communication about quality, or lack thereof, I guess.
Mm-hmm.
But thinking about that in many countries, it's becoming part of the practice of funders, public funders and others, to kind of start to publicize certain quality metrics about institutions. And in other instances, I think many times you see institutions or individual clinical practitioners holding themselves out as having to the public as being of a certain kind of quality, and using that information for various purposes. And you know, as you and others I'm sure know well, it wasn't that long ago when that was sort of a taboo thing to do, to speak about one's institution or one's practice as being sort of better than others, and to use that as sort of advertising and that kind of thing. So anyway, I'm just curious your thoughts on sort of the norms and normativity of quality communication in that aspect, and complexity.
I think that's a really important area, and you know, I was thinking when you were saying that perhaps it's increased, but I suppose it has probably increased from an individual or per institution self-promoting. There were probably the early 2000s, there were moves to construction. I don't know whether they're still there in the US, kind of almost league tables of healthcare institutions according to certain quality metrics. And I think, does that help? I think looking at the ethical issues that raises when those measures are imperfect, and when there are questions about just how much significant variation is there, are they all good enough to start with? You know, is there a sufficiency threshold that all are above, and that we're just talking about tiny little variations up at the top of something that isn't the measurement of which is not a perfect science anyway. I think raising questions and keeping those questions out in the public domain, if to the extent that these indicators are used for market share or used for competitive advantage, then calling out their limitations if the people who are using them aren't already doing so, seems to be something that we should be thinking about doing.
Thank you.
Thanks. I have a couple of questions, but I'm going to start with one. So you make very clear and hard to argue with points about what ethics has to contribute to quality improvement. I guess I'm sort of wondering how you could imagine that getting operationalized, and then well, why don't we start with that?
Yeah, I think that's a really good question, and to some extent the model that we were envisaging with the project is in part about holding conversations, so one way would be to think of people who somehow specialize in ethics. I hesitate to call myself an ethicist because I'm not sure I'm quite good enough at it, but working in parallel and in conversation with healthcare improvement specialists. So attending to their questions and their experiences, and what have been the sources of discomfort or the sources of questioning. Because I suppose the danger I've run in the caricature of a field is that I run the risk of not acknowledging that actually some health improvement practitioners, when they start reflecting on what they're doing, come across these kind of questions, are aware of some of the limitations, but are working in a framework or a system that gives them no space or no scope to. So I think that's one thing. I think I wouldn't want it to be a purely ethics scholars look in from the outside and identify all the problems with what's going on in healthcare improvement, because I think it's not like that. One of the things we've wondered about in the course of the project is, there's at one level everyone can and does do some kind of ethics. They think about what's good, what's right in their particular environment. And I think it's probably not come out yet, but we were asked to write a chapter for a guide to healthcare improvement, and we tried to propose a list of questions that healthcare improvement practitioners could reflect on. And that is one way, but then we run the risk of, well, we don't want to overburden healthcare practitioners with having to do all the ethical analytic work when they've got to act at the same time. So there's probably, I think, different models, which ideally anyone who's working in healthcare improvement is encouraged to think critically about what they do and given some kind of support to think through a bit further if they need to do that. But Joe was talking about oversight. There's often a level of a group of people who've got some kind of responsibility for oversight to produce some basic ethical checks about what's going on in healthcare research. So I don't have a neat answer, but I think again, and it's a bit of a cop-out, I think the construction of conversations between groups that come with different perspectives and areas of expertise is creating conversational space is likely to be something that's quite important.
Yeah, no, I think that is a good answer. And you said something else that I think is important too, which is that, building the awareness and competency within the field of people who really do want to do a good thing.
Yeah.
And, and just, as I was listening to you talk this afternoon, I was thinking, I was developing, more and more insights into the importance of what you were saying, but it wasn't immediately obvious to me. And, and then I started thinking, not just are there ethical considerations in how we define quality, but and what we choose to chase in terms of measurement. But, I started then remembering that I was working once in a practice where the effort was all around every patient who smokes has to be counseled about smoking cessation, which, I think most patients probably are anyway, but whatever. And I mean, it was a paper for performance issue, and the entire practice pivoted to ensure that this documentation was in place. And I thought, wow, there's a huge opportunity cost to that. And maybe it was worth it, but I don't know that anyone really put a lot of thought into making that decision.
Yeah. I think that's a great example. And it's one that we've certainly seen in the UK. At one point, primary care doctors being paid for that kind of thing, and it being impacting on all sorts of things. So I can remember a conversation with a health visitor, a kind of nurse who goes out to see usually mothers with very young children, and being required to ask about smoking on every visit. And when gaining access to the house to even just go and check that the baby was okay, there was, if there's distrust and what have you, kind of trying to impose that required conversation rather than being responsive to need. Huge opportunity cost.
There's something in the chat, someone asking about whether slides can be shared.
Absolutely, I will send those through to.
We will also, just to note, we'll be posting the recording on the Berman Institute's YouTube website, so that will also be available.
Thank you.
I think
all my mistakes preserved for posterity.
Yeah.
It's all your foresight.
We are out of time. I really want to thank you so much, Vikki. It was wonderful to see you and to hear about what you're working on. And I hope I see you soon. Thank everybody for coming.
Thank you all for listening. Thank you for having me. And I am very happy to follow up with people. I'm not always as fast as I like to be, but follow through. And I look forward to seeing some of the fellows after a short break.
Great.
Thank you.
Bye.